always good and bads for any situation. And I think with the goods of this pandemic, we got to know a lot of new people, and then we got to start being able to connect actually much easier. So these events, I'm hoping even after we get through this pandemic, we can just continue to educate each others. So Dr. Khairallah, he is he's becoming very well known in this field of getting. We're getting hammered with so many information, and all of us are scrambling to get updated. I have several sources, but one of my main sources of getting updates actually through Dr. Khairallah through his YouTube channel. So for those who are Arabic spoken, his YouTube channel is very, very actually powerful tool. I use it almost on a daily basis. So he put out videos that are easily basically understood in a very simple language and covers the most updated literature. So Dr. Khairallah, he is triple boarded. He has internal medicine and critical care from Wayne State University here in Detroit, and infectious disease from the Medical College of Wisconsin. He's currently the medical director of the critical care services at Sanford Healthcare System, and he is an associate professor at the University of North Dakota. So today he's gonna cover mostly the treatment, the most updated literature about the treatment of COVID-19, and then touch base on the most updated quickly on the vaccination. Before he starts, we're just gonna go what we were just talking. That's it would be good to have as much interaction, to be interactive as possible. So in the chat box, please go ahead and put out your questions or comments. And myself and Dr. Fadi will try to make sure that we pass this information right away to Dr. Khairallah and have it more of a discussion if possible. So thank you again, Dr. Khairallah. Go ahead.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Indeed, it's my pleasure to present at SAMS again and meet my colleagues here and learn from each other. Hopefully, we will have enough time to have questions and answers and learn from each other. The talk today is going to be kind of summary of all what's been happening in terms of management of COVID-19. And before we start, I want to remind you that it is very important that this definition is clear in our mind in terms of what do we mean by mild, moderate versus severe versus critical cases. And for asymptomatic and pre-symptomatic are those patients who do not have symptoms and got exposed to the virus and have the positive SARS-CoV-2 test. Those would be prior to starting symptoms. They may develop symptoms or may stay asymptomatic. We call a case a mild case if there are clinical symptoms that are mild, such as cough, fever, altered smell or taste, but no dyspnea. And there's no pneumonia manifestation can be found on imaging. Of course, there's no hypoxemia too. The case can be defined as moderate if we see radiological, if we have clinical or radiological evidence of lower respiratory tract disease. There's a pneumonia manifestation on imaging, whether it's chest X-ray or CT scan. However, there's no hypoxemia. The O2 saturation would be more than 94%, equal or more than 94%. In severe cases, it can be clinical with respiratory rate more than 30 breaths per minute. If we have hypoxemia, oxygen saturation less than 94% at resting state, and or if we have lung infiltrates of more than 50% of the lung fields, or we have more than 50% progression of lesions within 24 to 48 hours if it happened that a patient repeated chest X-ray or mainly CT scan. Critical cases would be shock or respiratory failure needing non-invasive mechanical ventilation or mechanical ventilation or ECMO. And of course, multi-organ system failure once we have 2 or more organs failing for more than 48 hours. Also, we learned that the course could be different from patients to patients. We may have the mild to moderate course where patients have the symptoms increased, and then without even any specific treatment, within a week or two, condition gets better and patient recovers. We also know that there is fluctuation. Patients may get better initially and then get more severe, have some hypoxemia, pneumonia, and after that recover. However, the most critical would be a course that starts initially with mild, moderate, and progresses into severe and may become critical. You would see some fluctuation. We've seen also cases where things get much better, and then after a week or two, things get back with severe inflammation, and they come to the intensive care unit, intubated, and severe cytokine storm. So we learned that we have a lot of thrombosis also, mainly in severe cases. However, we have observed thrombosis in mild to moderate cases and after recovery from mild to moderate cases too. The initial phase is mainly viral replication. With progression of the disease, we get into the inflammatory phase of the disease, plus thrombotic phenomena associated with the inflammation. With this in mind, I want to go to the main slide of the presentation, which is therapy. So I'm going to explain this slide, and then we go one by one and see what we can learn from it. So defined by the different stages of the disease, I'm going to focus that early on we need to direct therapies towards the virus itself. That's why you will see the antivirals been placed on this side. However, as we progress with severe and critical cases, we're going to start using anti-inflammatory, anticoagulation, and immunomodulators. Supportive care will be in all stages, and antibody therapy will actually be in initial phases, but it may actually progress into some of the severe cases. So in any selection of medications against COVID, we have to define which phase is the patient in. Are we dealing mainly with viral replication versus we started seeing some inflammation, and putting in mind that there is no separate lines between these phases. It is also one spectrum. Patient progresses from viral replication to eradication of the virus associated with inflammatory reaction in the body and cytokine storm syndrome. You see different color coding. If it is in red, meaning that the literature did support that this medication is not useful in the treatment of COVID, and you can see here that hydroxychloroquine, convalescent plasma is going that way also for advanced or severe cases. Lopinavir, ritonavir are all put in red. If it is orange color, meaning that we have data, however, we cannot make a decision with or against, and there is no emergency use authorization yet of that medication. And you can see that with the ivermectin, favipiravir, the interleukin inhibitors, zinc, vitamin C, and vitamin D. If it is light green, that means there is some data suggestive of benefit, and we have emergency use authorization from FDA. Whether this is going to change or not, we don't know. We need more data because this is just temporary authorization. It may change in the future. And if you have dark green color, that means that there is a clear benefit in a very well randomized control study that has not been challenged with different results yet. So with this, I'm going to move to the first thing, which is actually looking at whether we can benefit in giving hydroxychloroquine or ivermectin in the asymptomatic pre-symptomatic phase. So you can see that this is correlates with those stages one by one. So a lot of literature about hydroxychloroquine in mild, moderate, or severe, but the question is, and that has been risen multiple times, whether it can benefit in post-exposure prophylaxis. And there's a randomized controlled trial of post-exposure prophylaxis of COVID-19, and essentially there is no benefit of hydroxychloroquine. I'm not going to go into details to explain those studies unless somebody is interested in knowing this. And then the ivermectin story is started from Iraq, and then we have some studies coming from India, and we have one from South Florida. However, the interest here is when in the post-exposure, and the post-exposure is actually involved in the two studies from Iraq and India, and it shows that there is a decrease in the rate of COVID-19 disease from 10% for placebo versus 2% for patients who got the ivermectin. Similarly, in the Indian study, there's 73% reduction in the among healthcare workers in COVID infection after exposure. Based on that, I kept it in orange color. This is small studies. We need larger studies to be able to define more whether ivermectin might benefit in post-exposure. Of course, there are a lot of issues about ivermectin, whether we can achieve the therapeutic levels in blood with the dose that is advised. However, I'm just presenting the data, and that's why it is kept in orange. Moving to mild moderate disease with antivirals, what we have is Remdesivir and hydroxychloroquine. So Remdesivir has been authorized based on the benefit in severe disease. What about mild to moderate disease? There is a study that is published in JAMA and involved more than 500 patients with mild to moderate disease, and it showed that it shortens or has significant better clinical status versus standard care at day number 11. So there is something to suggest that the earlier we use Remdesivir, the better the results probably, which is standard for any antiviral. However, the medication is an IV medication. If anything, it has to be done in outpatient infusion center, and the medication should be given on a daily basis for 5 days. So it is really problematic. It would not be ideal for our patients to be given to everyone. Hydroxychloroquine, whether it's beneficial in mild to moderate disease, has been studied in this article that is published in New England Journal of Medicine, and the results are comparable. There is no benefit of hydroxychloroquine over the control in patients with mild to moderate disease. I think there's no argument anymore that hydroxychloroquine should be used in mild to moderate disease. Antibody therapy, we have at least now 2 different formulation recombinant antibodies. The Bamlanivimab that is authorized just recently showed in phase 2 study. This is only on 100 patients, different dosing regimens, 100 of 700 milligrams, 107 of 2800 milligrams, and 101 of 7000 milligram versus 156 placebo, so a little bit over 300 patients altogether, showed that hospitalization and emergency room visits decreased from 10% to 3% between the two groups. The patient selection for 12 years or more and have high risk of progression, such as patients with 65 or more and have chronic disease, defined in the article clearly. And they should be more than 40 kilograms or more, and it should be given within 3 days of first positive SARS-CoV-2 test. And in the same study, this is only available through the FDA website. There is no article yet published about the results of the bamlanivimab. However, in the same news article, it showed that oxygen, there's no benefit if the patient is on oxygen. So a patient should be given this medication prior to the need of oxygen. In fact, in patients who were on oxygen, they had worse clinical outcome. So we should be clear about not giving this medication if the patient is advanced with hypoxemia. The second medication that is authorized by FDA temporarily is Regenron, which is a combination of two different antibodies, makes the medication more stable towards any future mutations of the virus. It is also phase 2 study on close to 800 patients, showed that there is reduced COVID-19 related medical visits by 57%, from 6.5% down to 2.8% between the placebo and the intervention group. Almost the same criteria to be given to those patients who are at risk for disease progression, and also showed that there is no benefit for those patients if they require oxygen therapy, and it should not be given for them. The convalescent plasma, I could not find anything yet for mild to moderate disease. However, it makes sense if the bamlanivimab or Regeneron both work in early stage. We think that convalescent plasma may work also if it's given in early stages of the disease. Moving to the convalescent plasma in severe cases, I think we have now multiple studies that indicate that it may not be beneficial. That's why I put it in red. However, you can argue that there's some flaws in those studies, and maybe we need bigger studies. However, from our personal experience and our data also, we don't see that convalescent plasma is doing much to those patients once it gets to the severe stage. In the first study that was published in JAMA on June 3rd, showed that the mortality rate was, the clinical improvement was seen in 52% compared to 43% in the usual care, indicating that there is probably some benefit. However, if you take a look on the hazard ratio, it is very 1.4 with a p-value of 0.26, and the confidence interval is very wide, 0.79 up to 2.49. And then that is followed by the Argentinian study that was just published on a few days ago, November 24th. It is a randomized trial of convalescent plasma for those patients with severe cases, pneumonia and hypoxia or organ dysfunction. And it showed that there is no difference between convalescent plasma and placebo, whether we look at the results 7, 14 or 30 days after treatment. You can see the Kaplan, the difference between placebo and convalescent plasma. This is time from intervention to improvement, and you can see here the probability of death is also not different between the two groups. The last one that was published in BMJ, it's close to 500 patients, 18 years or more, severe cases with hypoxia also. It's a blasted trial in India, and the study shows that mortality rate was 44% compared to 41% in control, no clinical significance, and the study is negative. Based on that, I don't think we will have much to convince ourselves that convalescent plasma might be a good option for those patients. However, I know that this is still something that is used, and it should be actually colored in green because it has also a emergency use authorization from FDA. It may change very soon, as what happened with the hydroxychloroquine. Now we come to the antivirals. I'm going to talk about hydroxychloroquine, but now in severe cases. So that was in mild to moderate. There is no benefit. In severe cases, we have a very good trial, which is the recovery trial, showing no differences in terms of 28-day mortality in hospitalized patients between hydroxychloroquine and usual care. This is also shown in the Solidarity study by WHO with the mortality rate of 11% versus 9.2% with no statistical significance, indicating that based on these two large trials, the hydroxychloroquine is not effective in severe disease and should not be used. In terms of the remdesivir in severe stages of COVID-19, we have conflicting data. The initial ACT study, a CTT study that based upon the FDA has given the approval for the medication. It showed that it shortens the recovery time from 15 days down to 10 days with statistical significance, and trend towards decreased mortality. However, in the Solidarity trial by WHO, it showed that there is no difference between the remdesivir and the usual care in improving time for recovery. However, I should mention that the Solidarity trial used the medication for 10 days, and the medication is an IV medication, so that means the patient stayed in the hospital for 10 days. In the ACT study, it is only 5 days. And that could actually mask the benefit of decreased length of stay in the hospital or clinical recovery in those patients. However, it is still a strong study indicating that there is not much clinical improvement whether they stayed in the hospital or they were discharged. In the same article actually, but by WHO, the Solidarity trial, if you take a look closely, they listed actually all those trials that we have available in terms of the remdesivir, and you can see that you probably can see a signal here in those patients where they have a low flow oxygen, as indicated by the red circle here, and this is in the ACT study where the benefit is much more than if the patient was not on oxygen or if the patient was on high flow oxygen. If you take everyone together, the low risk group has a tendency to some benefit. You can see the range is 0.63, barely touching on the equal line or the zero line here. So based on this, we're still using the remdesivir in our patients. However, from our personal observation and our data in the hospital, we really do not see much of the benefits in those patients. Lopinavir, ritonavir has been looked at in the recovery and the Solidarity trial, and both showed us negative results and I don't think there's a role for this medication to be used in severe COVID cases. Again, back to the ivermectin, but this time is in severe cases, and the study from Iraq involved 70 patients. Its randomized controlled trial showed decreased time to recovery in addition to decreased mortality. A retrospective study from South Florida showed that ivermectin is associated with lower mortality in hospitalized patients with coronavirus. 173 patients in the ivermectin group versus 107 in the usual care group. It is retrospective in nature. Mortality rate was 13.3 versus 24.5. Like any other retrospective study, it has its own limitations. So based on that, I don't think we can make a recommendation. However, you probably know that Dr. Paul Marek is recommending the use of the regimen that includes ivermectin for all cases, including post-exposure, mild to moderate, and severe cases. Favipiravir is a medication that is used in some of the countries' protocols, such as Saudi Arabia, and there is a good meta-analysis that included multiple studies together. Forgot how many actually, but here I can see 1, 2, 3, 4 studies at least, and showed that there is some benefit in terms of clinical outcome, clinical improvement, but no benefit in terms of mortality. However, all those studies are, as you see, small studies. The maximum number of patients, 116 plus 71, is above 200 patients. So no, actually 116 plus 120, that's the largest study is 236 patients. Anyhow, it looks like there is some clinical improvement with favipiravir, but requires larger studies before we can accommodate it as a treatment options, and that's why I kept it in orange. Anti-inflammatory agents with dexamethasone, probably the strongest data that we have, and this is based on the recovery trial published as preliminary report in New England Journal of Medicine, and showed that mortality rate, 28-day mortality, was lower in the dexamethasone, 22.9 versus 26% for all hospitalized patients. If we look at the mechanically ventilated patients, it's even better. 41% versus 29% with the dexamethasone. If you look at the oxygen without invasive mechanical ventilation, 26% versus 23%. You can clearly see that there is a benefit of having steroids on board in invasive mechanical ventilation, mainly in patients who need oxygen, but there is no benefit for patients who do not need oxygen based on this study. And that's why now we start steroids for all those patients who come to the hospital with oxygen support or need of mechanical ventilation. In the same article, it shows that those patients who were younger benefited more than the elderly patients, and also patients who, males benefited more than females, and patients who stayed in the hospital for more than 7 days, patients who had symptoms for more than 7 days benefited more of dexamethasones compared to those patients who had symptoms less than 7 days. And in fact, those patients with, if we use steroids in early course of the disease, we may have a negative outcome compared to patients who do not use steroids. So I think we should be very careful in selecting our patients who need to be on steroids, and making sure that patients showing some signs of inflammation defined as hypoxemia in this study. And then it's been put together all the studies that use steroids, and the question would be, is it the right medication, dexamethasone, or should be other steroids? Is it the right dose? Should we use 6 milligrams, or we should use the 20 milligrams? We have the Dexa COVID-19, but you can see the number of patients, only 7 and 12, very weak study. We have the Codex that included more than 250 patients, and you can see the study did not show benefit. It crosses the line of equality. This is the recovery trial that has the major effects in this meta-analysis. This is for dexamethasone. They looked at the hydrocortisone in 3 different studies, the Cape COVID, and the dose was 200 milligrams per day. This is a low dose. The COVID steroid, also low dose, and you can see that it crosses the line of 1. Remap cap, 50 milligrams, also every 6 hours. The confidence interval is slightly crossing the line of 1. Methylprednisolone, not much impressive here. When everything put together, the data still showing that there is a benefit of adding steroids to the regimen. In the same analysis, those patients who are on mechanical ventilation benefited more, and patients who received steroids more than 7 days benefited more than if the patients who were symptomatic for more than 7 days benefited more than those patients who were symptomatic less than 7 days.
Dr. Khairallah?
Yes.
So, question from Dr. Aisha Hamid. When should you start steroids? And again, another question coming from Isam, Dr. Isam, about how long should the steroids be given in severe cases?
Well, we start steroids once the patient shows signs of hypoxemia, defined as oxygen saturation less than 94%. At that time, you would start the patient on dexamethasone. We are using 6 milligrams, exactly the same dose as defined by the recovery trial, 6 milligrams daily for 10 days. We are stopping at day number 10, regardless of whether the patient showed any improvement or no improvement. Some physicians may opt to continue further, but there is no studies to support that. Yes.
And those with COPD or asthma exacerbation, would you give it higher doses or longer?
Yeah. So if there's an indication other than COVID, we would use the medication that is known and studied in this population, like in asthmatic patients or COPDers. We use solimedrol, methylprednisolone, 40 milligrams BID, or the dosages that you're familiar with, because there's also a range of dosages for those patients. So this would be an exception to the dexamethasone use if there's an indication other than COVID-19. Okay, so we move to the anticoagulation, and this is, I'm very disappointed that so far, after almost a year since the start of this pandemic, we don't have robust data to be able to answer that question. And that what we have available is the study that is published in the Journal of the American College of Cardiology, and this is a retrospective study, not very powerful. However, there's a good number of patients. Total patients of 2,773, and it showed that those patients who were placed on treatment dose anticoagulation, indicated by the blue color here, had a better survival probability compared to those patients who did not have treatment dose anticoagulation, especially if patients were on mechanical ventilation. So you can see total number of patients 395 on mechanical ventilation, and you can see the separation in terms of mortality for those patients. However, this is a retrospective. There's confounding factors, there are unmeasured confounders, and there's immortal time bias in this study. So you cannot just completely rely on this to say, well, I would use treatment dose anticoagulation. So the strategies that you would decide in your ICU, that you would give intermediate dose enoxaparin to all your ICU patients, and probably there's, based on the observations and based on the autopsy studies, based on the rate of coagulation observed for those patients in the ICU, I think this is very reasonable to do in all patients. However, to do risk-adjusted full anticoagulation based upon D-dimer, this is coming from the early Chinese study that showed those patients with D-dimer more than 6 times upper normal limit benefited from anticoagulation. This is something that has been accommodated by many centers here in the United States and in Europe, and it's an option for you that you can do it also. However, there is no studies to support this strategy much. Of course, if you're suspecting or you have confirmed VTE, I think full anticoagulation is justified. A lot of times you have a patient with increased D-dimers, worsened oxygenation, worsened respiratory status, but you cannot do a CT scan to confirm VTE. At that time, you can start full anticoagulation for those patients. There's a recent study published in the American Journal of College Cardiology also, that showed, and is retrospective, all hospitalized patients. This is from New York, Mount Sinai, patients who were, they looked at their patients who had therapeutic anticoagulation 900, prophylactic anticoagulation 1900, and patients without anticoagulation. You can see the separation in the incidence of mortality between patients who received therapeutic or prophylactic anticoagulation. Patients who did not receive anticoagulation, I don't know why they did not receive anticoagulation. They did not mention that in their article, but those patients had a higher mortality rate. And if you take a look on closer look at prophylactic and therapeutic anticoagulation, you can see that there is a separation in terms of mortality between the two groups, indicating that there is probably a benefit of therapeutic anticoagulation. The confidence interval, not too bad actually, 0.73 to 1.02. However, we need more studies to be able to confirm this findings. This is a retrospective study and has its own limitations. There's a very nice case vignette in New England Journal of Medicine, I think just a few weeks ago, on October 22nd, where they presented a case and they put the two different arguments. I would highly suggest that you read it. It's really very interesting because you have very good convincing data and convincing information, about using intermediate dose anticoagulation and anticoagulation after hospital discharge. And this is challenged in the same case by other experts for only regular prophylactic anticoagulation and discontinue at hospital discharge. Going back to our diagram here, there is not much about the direct oral anticoagulant. I know that in the Middle East, a lot of patients are discharged home, or once the COVID is diagnosed, they are putting every single patient on enoxaparin 10 milligrams per day. There is not much to support the outpatient routine prophylaxis. They hear about a case here or there of pulmonary embolism, and then they jump on and give everyone anticoagulation. Full anticoagulation is not warranted. Prophylactic anticoagulation, probably it is based on case by case in patients with obese, limited movements, anything that would indicate otherwise that there is a need for prophylaxis. Nobody can argue about that.
Dr. Mazen,
Yeah.
what about if the patient has chronic kidney disease or end-stage kidney disease? What with high risk, what should we do?
Yeah, for enoxaparin, it can be changed to heparin for patients with GFR less than 30. Of course, you can adjust the dose, but I personally prefer not to use enoxaparin in patients with severe renal failure, GFR less than 30. In COVID patients, we don't know about direct oral anticoagulant, and it is not advised to give direct oral anticoagulant in hospitalized patients at all. So the medication in the hospital that we should concentrate on is enoxaparin, and we all know that enoxaparin, in addition to heparin, they both have anti-inflammatory properties that might benefit those patients too. Moving to the immunomodulator.
What about those who comes on anticoagulation already, like a patient is taking Eliquis at home and they are for AFib or different reason and they are admitted? Do you continue their own anticoagulation or you switch
Yes.
them to Lovenox?
Our practice has been that we keep the patient on the same anticoagulant that the patient has been on at home if they are admitted to the hospital. In the intensive care unit, we did not accommodate, this is for all hospitalized patients together. If the patient comes to the intensive care unit, we have not actually made a decision whether we should change to enoxaparin versus continue the same treatment because we don't have data to support one way or the other. So we left it up to the treating physician to decide whatever he wants to do.
One question about inhaled steroids. Dr. Hamid asking us about inhaled steroid.
There's no supportive data yet for inhaled steroids, so we're not recommending this because we know that systemic steroids might be beneficial for those patients. So I don't think we should recommend any inhaled steroids in place of systemic steroids. The inflammatory reaction is all systematic. It should not be localized only to the lungs. So if there's any benefit of dexamethasone or steroids, it would be coming from the systematic use of the medication. So I doubt if anything is going to be proven efficacious with inhaled steroids if there are any studies about that. To add that to the systemic steroids, I also doubt if there's any benefit, and we're not using any of the inhaled steroids. If somebody has any data about this, I would love to hear that or see it if you don't mind. Moving to the immunomodulators, the interferon beta 1 alpha, this is inhaled interferon, and this is shown negative study by the Solidarity trial by the WHO. The same trial looked at multiple agents, including Remdesivir and hydroxychloroquine, in addition to interferon beta 1 A and lopinavir ritonavir. So no benefit of the inhaled interferon. Interleukin inhibitors, just going to be talking about the tocilizumab here. We have 3 different trials. The Impacta, negative, no benefits. The Remdacta, it showed there's improvement in terms of progression to mechanical ventilation or death. 19% in placebo versus tocilizumab, 12%. This is not published yet. And also mortality was placebo was 8.6, tocilizumab 10.4. No statistical significance between the two. So it is, you can see when they combine, they play with the data, when they combine progression to mechanical ventilation or death, there is some benefit, but when you look at the mortality alone, there is no benefit with tocilizumab. So there's another trial that we're waiting for its results, Remdacta. Do not forget that we do have some late onset infectious complications that has been reported with tocilizumab. We're not using it routinely in our patients. Janus kinase inhibitors, before COVID, I really never heard of Janus kinase inhibitors, so I thought I would look at it. It looks like it's one of the modulators of cytokine actions. This is from the side of the company. The medication is called Parisitinib, and that medication blocks or inhibit the JAK pathway, and then decreases inflammation. This is only a news article also. There's a clinical improvement by 1 day only, 8 days versus 7 days with Parisitinib plus Remdesivir versus Remdesivir alone. And this is part of the NIH trial, the ACTT2. So we're going to see the results very soon of this agent. Did we leave anything here? I think that's it for. I'm not going to be talking about zinc, vitamin C, vitamin D. There are data about that, but still not robust data. I cannot make a recommendation one way or the other. However, it doesn't seem that there is side effects of these medications. I don't think it would enhance the inflammatory reaction as been suggested by some. So we are routinely giving zinc, vitamin C, and vitamin D to our patients. So if we move prior to the disease process here, we can go to the vaccination prior to this, and if we look quickly at what's available and how do they work, I'm not going to go into details, but what we're looking at is we need the body to form antibodies against the protein S of the virus itself. So it depends on how we're going to let this protein S get generated inside the body or introduced into the body. What we can do is we can take the RNA, put it on another DNA virus, or usually what they use is the adenovirus itself, coming from the chimpanzee. This is the basis of the AstraZeneca vaccine and the Russian vaccine. So just put the RNA inside the virus and then introduce the virus. The virus does not cause severe disease in the base. It's essentially inactive in humans, and it would not cause disease. However, antibodies will be formed against the virus itself and against the protein S that is going to be formulated inside our cells. We can put it on the DNA, but the DNA has to be incorporated into the host DNA, and there's some issues about that. There's not much advances done in certain viruses, certain vaccines, so I did not put the name of the vaccines here. We can also take the RNA and or we can form this RNA in the lab and put it in forms of messenger RNA and put a lipid capsule around it in nanoparticles and introduce it into the body. The RNA would go into the cytoplasm, the messenger RNA will be transcribed, and protein S will be formulated. Once the protein S is formulated, it will be introduced into the macrophages, or the antigen presenting cells in the body, and the body would interact by forming antibodies against it. We can also use the antigen presenting cells directly and put the protein S on them and then introduce them through the vaccines. Of course, those are more of a newer way. The traditional way is use the inactivated vaccine. This is most of the Chinese vaccines are done this way. Live attenuated, it's an Indian vaccine. Novavax, it's just working with the protein subunits, which is the protein S itself. And we can have the protein S on a virus-like particle too. So what we're looking for is efficacy and safety. If you see it in orange color, that means we have some safety concerns. You probably know that the AstraZeneca trial was halted in September, I believe. In the United States was restarted just a couple of weeks ago, and they just announced the efficacy data for them 2 days ago, 70%. The Sputnik, which is the Russian vaccine, you probably heard that was approved when it was in phase 2 only, like the Chinese vaccines too. They were all approved temporarily right after the phase 2, which is something that should not be done and cannot be done in the States here. They just released the efficacy results a few days ago with efficacy of 91.4%. You all heard the results of Pfizer and Moderna, more than 90% in both. And it's in green color because there's no single case of severe reaction that was registered during the trials. I think the Pfizer vaccine will be presented to FDA on December 10th, and we're probably going to be hearing something about that. By the end of the month, Moderna will be also presented. Sinovac vaccine efficacy 90%. There's some side effects. I think the study was halted in Brazil for a case that went bad. So we need to wait for their results also. Not much reported about the others. I just put the ones on the first line. And of course, it's very important that we look at safety and efficacy. And it is going to be problematic because there is a movement against using the vaccine. And in our decision in trying to convince people about the vaccine and whether they should take it or not, of course, for those people who believe that this vaccine is going to the virus is actually man-made and the vaccine is going to be created to control people, I don't think there's a scientific discussion that we can establish with those kind of people, because we do not have any data to prove what they're saying otherwise. However, it doesn't make sense at all. However, for those people who are skeptical about side effects and risk associated with the vaccine, they should know that the 1 out of 3 people in the United States develop shingles, and we have a vaccine for it. 1 in 300 would die because of COVID if they acquire COVID. The chance of dying of choking on food is 1 in 2,600. The chance of dying in flu is 1 in 4,000. The chance of dying of lightning strike is 1 in 160,000. The chance of having Guillain-Barré syndrome or anaphylaxis from vaccination is 1 to 2 in 1 million. A very small chance compared to, look at the chance of death if you acquire COVID. And look at the mortality that I put with COVID is less than 0.5%. So despite that, it's 1 in 3, and compared to the side effect that potentially could occur, Guillain-Barré and anaphylaxis. If you look at different other vaccines compared to the risk of death with COVID-19, look into it in terms of different age groups. And you can see here, this is data that is published in Lancet Infectious Disease, and took it from my friend Paul Carson, who presented this presentation few days ago. In the age group of 0 to 9, we have 50 hospitalization out of every 100,000 people infected with COVID, and 2 would die. So if you see that the risk associated with the vaccine is 0.1 for 100,000 anaphylaxis, 1 to 100,000 for intussusception with the rotavirus vaccine, 2.5 with the MMR, the ITP. Yellow fever is 0.4. It has some effect on the kidneys and liver, like yellow fever with the vaccine itself. Smallpox, we don't do it, but it was 1.2 out of 100,000. So the risk of the vaccine is even lower than the risk of the age group that has the lowest risk with COVID-19. Now, if you go up on the age group, you can see how the hospitalization risk increases and the death risk is increased dramatically till you get to age 80 and above. Look at this, almost 13% risk of hospitalization and 9% risk of death. 9,300 out of 100,000 patients would die because of COVID. So the risk of death and hospitalization, and I'm not talking about the long-term sequelae of the disease. You all experience that those patients do not recover easily. It takes weeks or months before they go back to normal life. So the risk associated with the disease, it's much higher than the risk associated with all the vaccines that we know. The other thing is people are worried about this is a very small studies that would not show if there's any risk associated, and that is not right. I think we can easily detect. Not sure if this slide is clear to you. On the left side here, we have the background rate in general population for any side effects, for any adverse event. Let's just say if we have a Guillain-Barré at a rate of 1 in 10,000 people, this is a normal rate in general population. Now, if we give the vaccine, we're going to have a 5-fold higher, or 10-fold higher, or 100-fold higher. How many patients do we need to include, or how many people do we need to include in the vaccine study in order to determine that risk? If we're looking at 5-fold higher, we need 16,000. If we go to 10-fold higher, we need 5,500. And we go down to 500 people if we have a risk 100-fold or higher. Now, if the background rate in general population is lower, 1 to 100,000, we need a higher number of participants in the vaccine trials, 160,000, 53,000, 2,500 here. And if we have a adverse event that occurs in the general population at a rate of 1 to a million, we need now, in order to detect this in a vaccine, we need to include 1,500,000 in the study. If it is 10 times, 500,000. If it is 100-fold, 2,300. So the number of patients included in phase trials in the Pfizer vaccine is 40,000 and 44,000 exactly, and in the Moderna is, I believe, is more than 30,000 also. So in most of the studies what we have here, we can detect this area here. We may not be able to detect a rare event if it is happening with the vaccine at 5-fold in only these areas here. So in most of the cases here, we will be able to detect this very confidently that the vaccine would be safe if we have a study limited to less than 60,000 people involved in the study. So we're confident that the studies that we have are effective or are good enough to show any adverse reaction. But don't forget that the studies are not terminated once we approve the vaccine. They will continue for 2 years, and there are also 3 different systems in the CDC and different agencies in the United States where they look at the adverse events occurring with different vaccines, and that would be monitored very closely. And they just added another level of safety by the CDC for healthcare workers. For us, we will have a day-by-day follow-ups for 2 months after vaccination, once we receive the vaccine, to report any adverse reactions. So for those people who are still worried about it, maybe they can wait 2 months to see what will happen to us once we get the vaccine. I think I'm going to be first in line when they approve this vaccine, and the vaccine will be given first to healthcare workers, mainly to those healthcare workers who have risk factors. The Pfizer vaccine has only 25 million doses, and the vaccine is given at 2 dosages, so it will be good for only 12.5 million people. And you probably know that we have close to 20 million healthcare providers in the United States, so Pfizer alone would not be enough to vaccinate all the healthcare workers. So probably by end of January we would be all vaccinated, or whoever wants to be vaccinated will be vaccinated. With this, I think I covered everything, and I wanted to end with this slide here. This is our treatment options at Sanford. Every patient comes to us, gets vitamin D3, vitamin C, zinc, and melatonin. We use dexamethasone for hypoxemic patients. We use intermediate dose enoxaparin as anticoagulation for all ICU patients, and we use regular dose for the floor patients. We use Remdesivir early on, and we use Regenron, and in fact Regenron and Bamlanivimab, we started using them as a single infusion outpatient in the outpatient infusion center for all patients who do not require oxygen. And with this, I would like to end with this tragedy has so far accounted for many lives of our healthcare workers around the world, in different countries, in the United States and everywhere else. I don't like to quote Stalin, but a single death is a tragedy, a million deaths is a statistic, and we don't want to continue looking at the statistics. We need to make an end for this, inshallah. Thank you very much.
Thank you, Dr. Mazen. So just, I'm going to start with the questions related to the vaccine. So the 2 questions: would there be any long-term effects of the mRNA vaccine in terms of increased malignancy? And the other related question: when do we acquire immunity? Do we acquire any immunity after the first dose of the vaccine or the second dose?
No. So the first question, we don't know. The vaccine has been studied for only 3 months. The FDA would need 2 months of monitoring after any reported side effect. Any adverse event occurred that would require the company to continue monitoring for 2 months. So I think the 2 months ended for Pfizer by end of today. So that's why I said December 1st. However, any long-term effects needs to be looked at in the surveillance and post-marketing surveillance systems that we have, and we would know whether there's any other side effects. The people are concerned about the mRNA. It doesn't get into the nucleus. The DNA gets into the nucleus. So the mRNA gets transcribed in the cytoplasm and gets degraded by the post-translational proteins in the cytoplasm, and then it will disappear completely. So the generation of the protein S is only for limited time. The second question is immunity is detected after the second dose. So the first one is weak immunity after the second dose, which is 3 weeks after the first one. By the end of week 4, we would have enough not only antibody titers but also T cell immunity. In fact, the T cell immunity is detected at good level after 14 days. The antibodies lack a little bit and they are detected after 4 weeks, and this is specifically for the Pfizer vaccine. Now the question should be asked how long this would last. I'm not sure if anybody asked this question. So we don't know how long. However, we know that the virus is not changing at rapid rate compared to influenza. So in terms of whether this would be effective, yes, it would be effective against the virus as long as the virus is not changing much. But whether the immune reaction would stay in the body or not, this is yet to be studied. I suspect it's going to be good for at least a few weeks, a few years.
But it's not going to be like yearly vaccine, we don't know.
The yearly vaccine depends on the mutations occurring with the virus. So far, the rate of mutations occurring with the virus is very low compared to the influenza virus. So we do not think that's going to be needed yearly based on the mutations of the virus. However, if the immunity of the person is decreased because of the immunoglobulin levels decreased, at that time it would need to be boosted.
Question, would you check the antibodies of the patients before vaccination if he was infected and cured before?
Yeah, so the thing is, let's just say first, do they have priority to be vaccinated? No. Those patients who were infected with the virus, they would need to wait in line till others who are not infected to be vaccinated. The second question would be, well, what about their immune system? How long do they stay immune? So this is, you probably know that there's multiple studies in the literature so far showing different results. Initially, a couple of studies showed that immunity does not last more than 3 months. Another study came out 5-6 months, and now we know that it is longer than this. And there's T cell immunity that is also longer than the degradation of T cell immunity in those patients is very slow, and it's expected that they would have immunity for 2 years. So if you're going to forget about the T cell immunity for those patients, you're going to follow only the antibodies. So you would need to measure the antibodies before you vaccinate those patients. However, the other argument would be after 6 months of illness, just vaccinate everyone if you have enough. We're thinking that by July we should be in, at least I'm talking about the United States, by July we should be able to have enough vaccines to everyone. So everyone who wants to be vaccinated, it would be vaccinated. One of the forgot what's his name actually came on one of the TV channels and made a commitment that by end of April everyone who needs to be vaccinated would have the vaccine. So I doubt if that's the case. I think it's going to be till July.
How about like pregnant women or younger age groups?
Pregnancy is not studied in it. All the trials did not include pregnant women, so they would not be vaccinated. It's not recommended yet. However, we're relying on the herd immunity. And in children, only Pfizer started a trial now to look at the efficacy in children and the safety. So in the first months of after releasing of the vaccine, it will not be including kids. However, you know that the children's rate is relatively lower and the severity is lower. So anyhow, they are the last on the list in terms of getting vaccinated. So I think they would be included. They may extrapolate data from adults towards kids, but if we get more solid data from any of those vaccine companies would be great. So Pfizer is doing a study right now, and we should get results by March, hopefully. Similarly, we don't know about lactation.
Okay, thank you, Dr. Mazen. A question: would you still carry the disease after successful vaccination?
Well, yeah, this is something that we need to look at. What we want is not only prevent the disease, we need to prevent transmission. So you may get the virus. The virus may replicate in the nose, and you may transmit it to others. However, because of the antibodies, you're not having the disease. But the viral load would be very low here, and if the viral load is low, at that time, transmission rate is going to be less. And at the end, with this all together, if we vaccinate 70% of people in the United States, we're going to get to the level of herd immunity, and then the disease would at least be controlled in a way that will be diminished with time. Hopefully, we can eradicate it completely. Yes.
They're asking about pregnancy. Any reported data if you extracted or you basically got infected with the COVID-19 in the first trimester?
In the first, yeah.
The newborn.
Yeah, I haven't come across anything specific in terms of effects on the fetus. However, it is similar to any other viral or febrile illness. It depends on the severity. You may have premature delivery later on, and of course there are reported cases of transmission to the fetus of COVID-19 if the woman is infected at last few weeks of pregnancy. But the effect of the fetus in the first 3 weeks, I have not come across any specific any specific problems.
Perfect. So it's almost has been over like 90 minutes. So we're gonna go ahead and end the session. We appreciate all the information that you gave. I'm sure you're exhausted from working so much, and now we've added to your tiredness with this long presentation. But we appreciated all the knowledge that you gave. I'm gonna apologize to all the people who sent questions. We have many other questions, but I'm gonna actually pass all these questions to Dr. Khairallah so we could try to find a different way, hopefully, to answer all these questions. And hopefully we'll have more sessions like this in the future. Again,
I have no problem for 15 more minutes if you want. I was planning till 9 o'clock, but that's up to you if you have more questions.
Sure.
But yeah, so we can actually, let me just, like we have actually questions.
Yeah, any testing tools that allow checking the viral load, will this be helpful?
Any testing tool to check the viral load?
Check the viral load, would that be helpful?
Helpful in what?
In the disease progression, estimating the disease progression.
What we rely on is the cycle threshold. So the lower the cycles, the higher the load. So of course it gives you an indication that the viral load is higher. But what you going to do about it? If you have a patient with a very low cycle threshold, well, he has a high viral load. So number one, viral load can correlate with severity and correlate with immunity at the same time, because you have more viruses, you get more immune. So So in terms of controlling the pandemic, it's not going to help much to know which patient has the highest viral load. They all have to be isolated. They all have to be.
So very great presentation. I like the simplicity of the first slide, and you went through it. So the only comment I have, when do you? There was no timeline on the slide. Like there's no timeline. Week 1, week 2, week 3, week 4. So when you decide to discharge the patient, if the patient has been in the hospital for 2 weeks, let's say on a 3-4 liter of oxygen, when it is safe, you say this patient can go home.
Well, you probably all know that timing is different from one patient to another. However, in general, patients get worse between 7 to 12 days after acquisition of the virus and after symptoms, I'm sorry, after starting of symptoms. So 7 to 12 days would be the peak time for worsening of the condition. And after that, the risk will go lower. So if the patient's improving and oxygen level is getting better, you may discharge the patient home. We usually not discharging anybody who's requiring oxygen more than 4 liters. I think here there's a requirement also, but I don't discharge patients home myself actually. But I think there is requirement from Medicare that there's a certain level of oxygen that they can pay for when they get home. Because once I heard that over 4 liters, anyhow, the policy in our hospital is 4 liters or less. If we can provide this at home and we can monitor the patient remotely with a video on a daily basis and the patient has access to healthcare, at that time we're discharging patients home. And we're also doing Remdesivir outpatient. So we're not, number one, we made a decision that if the patient is getting better, we're not continuing Remdesivir. So the patient doesn't stay in the hospital just because of Remdesivir. And the other thing is we're doing Remdesivir outpatient. Patient, if he's qualified, he can come to outpatient infusion center. I think with the approval of the Regenron, we're going to use less and less Remdesivir and use more Regenron for those patients.
If we have a patient on vent with hypoxias out of proportion to the infiltrate on the basically CT scan of the lungs, would you recommend full anticoagulation even if the PE study is negative?
Again, this, if you ask different people, you get different answers based on that. I usually do not give full anticoagulation to any of those patients, even if the D-dimer is more than 3,000. I only give it if I have a suspicion of pulmonary embolism that I cannot confirm. I do not routinely give. In fact, actually, I just gave a patient today full anticoagulation based on infiltrates bilaterally and sudden worsening of oxygenation. That I could not get a BE study for that patient. Routinely, I do not use risk-adjusted anticoagulation for those patients.
Question. I have seen severely sick patients in the ICU who continue to be hypercapnic in spite of high minute ventilation provided on a ventilator. Have you noticed something like this in your patients, and what's the solution?
Those patients would need to be anticoagulated. This is a dead space disease. And dead space disease is caused by thrombosis. So you need to rule out. I would get PE study if you can do it for those patients to confirm. The other thing is with the PE, you're getting negative PE studies because of this is not embolic disease. It's in situ thrombosis. And usually they are peripheral. They are not central. So we do the PE study is not sensitive for peripheral thrombosis. So that's why most of those are coming back negative studies. So in those patients, if you don't have an explanation, you're telling me that you have a good tidal volume, so that's a dead space disease. If it is dead space disease, you cannot explain by high PEEP, for example. You're not using PEEP of 16 or 18. Well, the only other PEEP can compress the vessels and cause dead space for my colleagues. And if there's no other explanation for the dead space disease, at that time you may consider the pulmonary embolism or thrombosis.
And long-term consequences of the infected patients, like anything that we know more now?
Well, you mentioned my YouTube channel. Actually, you probably know that my YouTube channel was directed mainly towards critical care and physicians mainly. And then by default with this, I don't know how, I was invaded by all this public. And now I get 100, 150 questions on a daily basis, if not more actually, about those symptoms that persist. And from all the studies, we have number one, persistence of these of symptoms, and number two, we have end organ dysfunction. So the persistence of the symptoms, 40% of people would continue to have weakness, and 35% shortness of breath, and even foggy brain, memory loss in 20-25% of cases. And 25% of patients would develop some types of chest pains that is very annoying, because whether this is something related to the heart or not. On the other hand, we have evidence of, in one study, 70% of patients had evidence of cardiac inflammation, previous or current, and we have effects on the lungs with the pulmonary fibrosis. Huge consequences of the disease itself that last for weeks to months. So we're talking about, in one study, after 4 months, 30 to 40% of patients are still complaining of those kind of symptoms. There's a possibility that we're going to be dealing with chronic fatigue syndrome and myalgic encephalomyelitis. This is the new terminology for the chronic fatigue syndrome. I think everything fits the chronic fatigue syndrome. I have diagnosed 2 patients so far. It has to last more than 6 months after the symptoms start, and has a specific criteria to be identified exactly before you make the diagnosis.
We have a question about use the aspirin in patients at home, discharged patients at home, using aspirin 325 milligrams. Dr. Aisha is asking.
Again, I don't think this is the. It's okay to use it for 4 weeks. However, there are no studies to support this. I do not give it. I do not give any anticoagulation if patients discharge or they ask me. Unless there's an indication, as I mentioned, obesity, not able to move, there's indication for prophylaxis. But I know that this recommendation, and mainly we're doing it for patients with chronic diseases associated with COVID. They like to keep those patients on some type of anticoagulation, starting with aspirin, 325 milligrams for 2 to there's 35 days in the literature. I don't know in some of the recommendations. I don't know where's that coming 35 days exactly. And then direct oral anticoagulant number 2 and number 3 sub-Q enoxaparin. I cannot blame people who are using it because I cannot say that there is a study to say no, it's not beneficial.
And they're asking about your personal experience in offering ECMO to patients critically ill beyond 10 days on the vent with refractory hypoxia.
Nobody is going to accept it beyond 10 days. The criteria is limited now for patients who can benefit the most, and those patients who are younger than 65 years old, BMI less than 45, and the disease less than 10 days. So if you find a center who accept these patients, you'll be lucky. Actually, we're having difficulties getting our qualified patients to get into ECMO.
Yeah, that's true. Multiple areas said they don't take ECMO for they don't accept transfer patients for ECMO in Michigan anymore. So, question about if you have a persistent granulopathy on the CAT scan and evolved into fibrosis, the pattern suggestive organizing pneumonia, would you continue the steroids at this point or restart the steroids?
Yes. So the short answer, if you have a reason why you would use steroids for those patients, yes. And that would be cryptogenic organizing pneumonia, where the benefit of steroid, we don't know if it's going to be beneficial. Number one, it's going to be difficult to differentiate between cryptogenic organizing pneumonia and pulmonary fibrosis following the but if you have the fleeting infiltrates, some fever, patients still having symptoms, it's not fixed disease, you see it is actually something that you can treat. At that time, yes, you can give steroids with the usual dose for the COP.
It's more an ethical question, like having such a high price for Remdesivir with the current conflicting data. Would you say that a person living overseas needing to pay a big amount of money for this medication, would it be justified?
I don't think so. I'm making recommendations overseas not to worry about this medication at all. I don't think there's a benefit of this medication that is justified. You know, we're talking about disease with this best study that we have is only improvement in the disease progress. So the clinical improvement is from 14 days down to 11 days. It's not worth the money. And then the solidarity study did not prove this. So the solidarity study, in fact, WHO is recommending against the use of Remdesivir for those patients. So better to make these recommendations in area where we need to direct these resources towards other modalities that have better outcome.
And in your hospital, you mentioned melatonin for every patient. Is there any data or any benefit to this?
Yes, theoretical data, theoretical concept of melatonin has anti-inflammatory properties that might be beneficial, and there's some data showing that melatonin is associated with improved outcome altogether, but those are very weak studies.
Perfect. Again, now it's 10 p.m., so we're going to try to stick
Perfect.
the extra time you gave us. I appreciate it again, Dr. Mazen Khairallah, and we hope that in the next few months we'll try to get together again for another update. Thank you again, and thanks for all the participants that came in or shared with us all these questions and insight. And we'll have this session recorded, so we'll share it through different channels. Thank you again, and have a good night.
Thank you very much. Appreciate it.